As I examine this frontal chest radiograph of a skeletally mature patient, the first finding that catches my attention is the apparent cardiomegaly, suggesting an enlarged heart. Additionally, there is airspace opacification in the right mid-zone of the lung, which I suspect to be of an infective origin, possibly pneumonia. The lungs otherwise appear normal without any significant pleural effusion or pneumothorax. However, upon closer inspection, I notice subtle underlying skeletal abnormalities, particularly in the anterior rib ends, which appear widened, and the humeral heads that seem slightly dense with some flattening of the contour of the left humerus. These findings are subtle but could be indicative of underlying chronic conditions such as sickle cell disease. Given the constellation of findings, cardiomegaly, airspace opacification, likely due to infection, and the skeletal abnormalities, the most likely diagnosis in this scenario is an infective exacerbation of sickle cell disease. The skeletal changes observed, such as the widened rib ends and dense humeral heads, are consistent with chronic hemolytic anemia and bone marrow hyperplasia typically seen in sickle cell patients. The cardiomegaly could be related to chronic anemia, which is a common complication of sickle cell disease, leading to high output heart failure or other cardiomyopathies. While considering the differential diagnosis, I would also keep in mind other causes of these findings. For instance, the skeletal abnormalities could be related to other hemoglobinopathies or conditions like thalassemia. However, the presence of cardiomegaly combined with the skeletal changes makes sickle cell disease the more likely diagnosis. Infective causes of the lung opacification, such as bacterial pneumonia, are highly probable, especially in the context of sickle cell disease, where patients are prone to infections due to functional asplenia. To further evaluate this patient, I would recommend a full blood count and a peripheral blood smear to assess for sickle cells and other hematological abnormalities. Additionally, I would consider a chest CT scan if there is any uncertainty regarding the extent of the lung infection or if there is a need to rule out other complications like a lung abscess. MRI of the shoulders could confirm a vascular necrosis if clinically suspected. In terms of management, treating the infective cause of the lung opacification would be the priority, with appropriate antibiotics based on likely pathogens and the patient's history. Supportive care, including pain management, oxygen therapy, and hydration, would be crucial in managing the sickle cell crisis. If the patient's anemia is severe, transfusion therapy might be necessary. Lastly, close monitoring for any complications, including acute chest syndrome, which is a severe complication in sickle cell disease, would be essential.